Good afternoon. My name is Jonathan Lyons from the Laboratory of Allergic Diseases at the NIH, and it's my pleasure to moderate this final session of what I think has really been an excellent virtual symposium put together by the great staffs of the two institutions that are hosting. This afternoon, we have three really outstanding speakers, I think, for this session entitled Treatments That Invoke Tolerance in Allergy. Without further ado, I'd like to introduce our first speaker, whom I had the privilege of knowing for actually almost a decade now, having rotated through clinic some 10 years ago at Children's with him during my training. A great experience actually that he was involved in sort of setting about this sort of the clinical collaborative efforts between the allergy and immunology groups, both at Children's and at NIH. So Dr. Hemant Sharma received his medical degree from Columbia University and went on to train in pediatrics at Duke, where he was subsequently served as a chief resident in pediatrics. Following his time at Duke, he completed his fellowship in allergy and immunology at Hopkins, where he also received a master's in clinical epi from Bloomberg School of Public Health and became really an expert in the evaluation and management of pediatric food allergy, training there with Bob Wood. So after he completed his training there, he was recruited to be the director at Children's National of the Food Allergy Program and has subsequently really risen through the ranks over the past several years to become the chief of the division of allergy and immunology, as many of you know. He's contributed to over 35 peer-reviewed manuscripts, reviews, and book chapters, and plays really an active role in the field of food allergy, not just in clinical research, but also education and patient advocacy, for which he's received both regional and national recognition. And so today he's going to be speaking with us about emerging biologic therapies for food allergy. Hemant?
All right, thank you, John, for that very kind introduction. And thanks to the conference organizers for the opportunity to discuss, as John mentioned, emerging biologic therapies for food allergy. My disclosures are shown here. I am the site PI for a clinical trial of Depilomab and peanut oral immunotherapy. However, that study is still ongoing, and there's not any findings released or published yet. So why do we need novel therapies for food allergy? Well, much of this relates to the sheer burden of this illness. Food allergy affects 8% of kids in the United States. Over 40% of those are allergic to multiple foods. And the prevalence of food allergy is steadily increasing at a rate of about 1.2% per decade. And this is obviously associated with rising healthcare costs as well in terms of ED visits and hospital visits. But really, why do we need therapies relates to the fact that the mainstay of management for this illness for the longest time has been just strictly avoiding the allergens and always having access to emergency medications. Just within the past year, the first FDA-approved therapy for peanut allergy has come onto market, Palforzia, which is a peanut OIT product. But still, for many patients with food allergy, the standard of care will simply be to avoid their allergens and have access to their emergency meds. Much of the work that has progressed over the past decade has looked at allergen immunotherapy. And this is going to be discussed in greater detail by Dr. Davis in the next talk. But this just shows a schemata of what typical OIT clinical trials might look like. An initial screening period where the level of reactivity to the food is determined through an initial food challenge, followed by updosing, maintenance, and then another food challenge to determine how successful the desensitization was. And then many trials will then stop treatment with the OIT and then perform another food challenge to assess what's called sustained unresponsiveness, which is a surrogate marker of actual tolerance. Has the food allergy resolved without having continuation of the OIT? Well, why then is there an unmet need if there's been so much progress in the field of food immunotherapy, whether oral, epicutaneous, or sublingual? This relates to some of the limitations that we've observed with each of those forms of immunotherapy. First off, the updosing phase for many of these protocols is months long. And really the ideal food allergy therapy would have a much more rapid updosing period of weeks rather than months. These therapies are also not without risk of adverse events such as chronic gastrointestinal complaints, for example, with OIT, but also a risk of anaphylaxis. In the AR101 or the Palforzia studies, the rate of anaphylaxis was 4.4% in the active group versus 0.8% in placebo. And so ideally, there would be a low risk of adverse events and systemic allergic reactions. Another potential limitation is that many of these protocols are food allergen specific. And given that we know that 40% at least of patients, pediatric patients with food allergy have more than one allergy, the ability to treat multiple food allergies simultaneously is really important. And then finally, protocols to date have not been successful at inducing permanent oral tolerance or cure as measured by sustained unresponsiveness. For example, a recent meta-analysis found that after 5 years of peanut OIT, about half of patients were able to tolerate peanut after 4 weeks off of therapy, but that decreased to only 15% after 6 months off of therapy. And so really identifying something that induces permanent tolerance after cessation would be the ideal curative goal. And so for some of these reasons, that's why biologic therapies are of particular interest, either as an adjunct to immunotherapy or separately as monotherapy, because it may help to meet several of these unmet needs. So looking at potential targets for IgE-mediated food allergy with biologics, it's helpful to consider the pathophysiology of initial sensitization of food and also reactivity to food upon re-exposure. And so due to disintegrity of the epithelial barrier, food antigen gains access across the epithelium, activates alarmins such as TSLP, IL-25, IL-33, which then induce dendritic cells to activate, to encourage naive T cells to differentiate into Th2 cells, which then elaborate Th2 cytokines such as IL-4, 5, 9, and 13, which then encourage isotype switching towards IgE preferentially. And that IgE then is bound to the surface of basophils and mast cells, and upon re-exposure to the allergen causes the early and late phase responses. So you can see here 3 biologics that target particular aspects of this cascade. Omalizumab in the middle, or anti-IgE, Depilomab, which is an anti-IL-4 receptor antibody that blocks IL-4 and IL-13, and then on the left, Itocamab, which blocks IL-33. So those are 3 biologics that we will discuss in greater depth, some of the findings so far. There are several others potentially in the pipeline, including targeting of TSLP, IL-5, IL-9, as well as IL-13. But as mentioned, the vast majority of work so far has really focused on omalizumab, or anti-IgE, both as adjunctive therapy as well as monotherapy. And there are emerging studies looking at Depilomab, anti-IL-4 receptor as well, both as adjunctive as well as monotherapy, and then some very limited work looking at anti-IL-33. But starting first with omalizumab as an adjunct to peanut OIT, back in 2012, Henson et al. Published a very small pilot study of 6 patients who were treated with omalizumab for 4 months before peanut OIT. And the main findings from this small study were that those patients treated with omalizumab were able to start at a higher median initial peanut OIT dose. And from a safety standpoint, they also had fewer reactions on dose escalation days in the omalizumab treated group versus placebo. This was followed in 2013 by a study by Schneider et al. 13 patients treated with omalizumab for 3 months before peanut OIT. And one of the striking findings from this trial was that all of the patients reached a dose of 500 milligrams of peanut on day 1. Just to give that some context, 500 milligrams of peanut is about 1.5 peanuts. And the only FDA-approved product, Palforzia, the maintenance dose after months of therapy is 300 milligrams, or about 1 peanut. So in this trial, all patients were able to reach a dose even higher than that on day 1 after pre-treatment with omalizumab. 12 patients out of the 13 reached a maintenance dose of 4,000 milligrams of peanut, and then went on to tolerate 8,000 milligrams at challenge more than 12 weeks after omalizumab was stopped. In 2017, McGinnity et al. Conducted a larger study with 37 patients treated with omalizumab versus placebo for 3 months before starting peanut oral immunotherapy. And similarly, these subjects underwent a rapid one-day desensitization of up to 250 milligrams of peanut, and then weekly increases up to 2,000 milligrams, followed eventually by an oral food challenge 12 weeks after discontinuing omalizumab. And on the figure on the bottom left here, it's displayed the dose of peanut that was tolerated on the initial rapid desensitization, the first day of treatment, by treatment group. And you can see on the left for the omalizumab treated subjects, there was a median tolerated dose on that first desensitization day of 250 milligrams versus just 22 milligrams in the placebo group. And then looking at some of the subsequent outcomes, food challenge, looking at 2,000 milligram tolerance after discontinuation of the omalizumab or the placebo, you can see that 73% of the omalizumab treated patients tolerated that 2,000 milligrams of peanut versus just 12% of the placebo. And then after 12 weeks post study drug discontinuation, 76% of the omalizumab treated patients passed a 4,000 milligram challenge versus just 12% of the placebo treated patients. And so this study for peanut allergy suggested that there can be particular benefit both with initial escalation and also eventual evidence of desensitization. In 2016, Wood et al., my mentor at Hopkins, conducted a clinical trial looking at omalizumab for adjunctive therapy for cow's milk, OIT. And these patients were treated with omalizumab or placebo for 16 months, with the milk OIT started at month 4. And as you can see, several findings were similar. First, in that there was a shorter period of updosing, 25 weeks in the omalizumab treated group versus 30 weeks in the placebo. However, there were not significant differences in either the desensitization or the sustained unresponsiveness outcomes as shown here in this table, 88.9% versus 71% at month 28 challenge and 48 versus 35 at month 32. However, the safety profile was favorable in that the omalizumab treated group had significantly fewer symptoms, both during updosing and also had no dose-related reactions at all during treatment, requiring treatment. That same year in Spain, Martorell et al. Conducted a trial also looking at omalizumab as adjunctive therapy, in this case for patients who had failed conventional milk and egg OIT, who then went on to be treated with omalizumab for 9 weeks before starting rush OIT to milk and to egg. This was an open label, uncontrolled study. It was found that all of the patients did tolerate desensitization challenges on omalizumab. However, after stopping omalizumab, half of the patients had reactions to OIT within 2 to 4 months. And so this finding suggested that perhaps longer dosing of omalizumab may be required than just the 9 weeks that was done here. Now, as mentioned, many patients with food allergy are not allergic to just one food, but they're actually multi-food allergic. And so omalizumab has also been looked at as an adjunctive therapy to multi-food OIT. In 2014, Begin et al. Did a phase 1 open label study, omalizumab for 8 weeks before starting rush initial escalation to 2 to 5 foods, either peanut, milk, egg, tree nuts, grains, or sesame. And then these subjects remained on omalizumab for 8 additional weeks. And it was found that 76% of the patients tolerated a sizable dose of the food allergen, 1,250 milligrams on the day 1. And all of the patients then went on to tolerate an increase to the goal dose of 4,000 milligrams per allergen within 9 months. While there were reactions, all of the reactions were mild. There were no moderate or severe reactions, and only 5% of the home doses. There were no increase in reaction rates after omalizumab was stopped. More recently, in 2019, Andorf et al. Have conducted 2 studies looking at adjunctive omalizumab to multi-food OIT. The first was a phase 2 open label study of patients treated with omalizumab using a similar protocol as the BEGIN study, and also found that more of the omalizumab treated patients tolerated the 2,000 milligram dose of at least 2 different food proteins at exit challenge. And then another study by that same group was a blinded study, double-blinded RCT of 48 patients treated with omalizumab versus placebo for 16 weeks using a similar protocol. And similarly, a much higher percentage of the omalizumab treated group tolerated 2,000 milligrams of at least 2 different food proteins at exit challenge. Of note, also, the placebo group achieved a lower dose on initial dose escalation day and took longer to get to maintenance. And this also showed a similar safety profile, which was favorable. So based on these findings, the NIAID-funded Consortium for Food Allergy Research has actually an ongoing multi-center phase 3 double-blind controlled trial of omalizumab and multi-food OIT, seeking to enroll over 200 patients with peanut allergy and at least 2 of these additional food allergies. What about monotherapy? So back in 2003, Lyons et al. Had conducted an intriguing RCT of an anti-IgE product called TNX-901, which never eventually made it to market, but this was given every 4 weeks for 16 weeks. And it was observed that there was an increase in the mean eliciting threshold peanut dose in the active treatment group versus the placebo group from entry to exit. And so this obviously raised intrigue about whether omalizumab, independent of any OIT, might have a beneficial effect on food allergy. And so in 2012, Savage et al. Conducted a 6-month open label study of omalizumab for peanut allergy and found a significant increase in the threshold peanut dose between the entry and exit challenges just with the omalizumab treatment. And they presume that this might be related to basophil histamine release, which was suppressed early in treatment, potentially due to interaction with the Fc epsilon receptor on basophils. In 2018, the FDA granted breakthrough status to expedite approval of omalizumab. And since then, very recently, in 2019, a real-life observational study in 15 children who were treated with omalizumab for severe asthma showed after 4 months of omalizumab treatment an almost 9-fold increase in allergen threshold for several different food allergens. You can see in the consort diagram here of the 15 patients who had data available pre and post omalizumab treatment, 9 of them developed full tolerance to all foods, 2 of them developed full tolerance to at least 1 food, and 4 of them developed partial tolerance. None of them had no difference in their level of tolerance. And on the right, for some of these individual foods, wheat, egg, milk, and baked egg, you can see the increases in the threshold doses initially and then after treatment with omalizumab. So most of the work has been done obviously on omalizumab, but Depilomab is also of interest. And in 2019, there's one case report suggesting an adult who had resolution of tree nut allergy while being treated with Depilomab for atopic dermatitis. And so there are 2 ongoing phase 2 trials comparing the efficacy and safety of Depilomab, one of them looking at as monotherapy and the other as an adjunct to peanut OIT. And then finally, Itolizumab, anti-IL-33, one study, a small study, found that patients treated with 1 dose of that did have increases in their tolerated threshold dose, as well as some biomarker changes in terms of decreases in their peanut-specific IgE, as well as decreases in IL-4, 5, 9, and 13, and CD4 positive cells in the active group upon peanut-induced T-cell activation. This product, after unfavorable findings in an atopic dermatitis study, really hasn't progressed much since then, but this remains an area of potential interest in the future. So just to summarize, there's been quite a bit of work looking in particular at anti-IgE or omalizumab as an adjunctive therapy due to the limitations that we've observed with OIT alone. And some of the benefits might be decreased time to desensitization, better safety profile, and the ability to simultaneously desensitize to multiple allergens. In addition, biologics such as omalizumab may exert a non-specific, non-allergen specific effect on food allergy as monotherapy by rapidly increasing allergen thresholds. But obviously, very limited studies to date, and more studies are needed and larger control trials to establish both the efficacy and also the mechanisms of action. Thank you very much.